Thank you so much. Good morning, everyone. Thank you so much, and very honored to be here. First of all, I want to, I'm an Italian OBGYN. I've been working in Mozambique for the last 18 years, and I'm part of the PMTCT Technical Working Group at the Ministry of Health. And I'm also a PhD candidate at the University of Nova Lisboa in Portugal at the Institute of Tropical Medicine and Global Health. I'm here on behalf of the TWG, of the Ministry of Health TWG, and I'm presenting the results of a retrospective evaluation of an MOH risk screening tool for identification of high risk of incident HIV infection among breastfeeding women at the pediatric immunization services in northern and central Mozambique. I have nothing to disclose. I want to say that, of course, I'm here on behalf of the PMTCT-WG, but this evaluation was carried out with the big support of the implementing partners, ICAP, Columbia University, CISAUD, and Ariel Foundation, but especially with the big support of CDC Mozambique and the amazing team of the MCH branch at CDC Atlanta. So thank you. Just to say, I think we have seen in the previous presentations that incident HIV infections in pregnancy and breastfeeding are a major driver of MTCT. For Eastern and Southern Africa in 2023, 31% of new pediatric infections were from incident maternal infections in pregnancy and breastfeeding, and for Mozambique, they represented 28% of new pediatric infections. In these settings, in high HIV burden setting, WHO recommends repeated testing early during pregnancy, in third trimester, and at least once during breastfeeding. So for us in Mozambique, you've also heard women, pregnant women, children are really impacted still a lot from HIV. We have still a high vertical transmission rate of 9.7% according to 2023 data. Ministry of Health guidelines drive the guideline that breastfeeding women with an unknown HIV status have to be offered HIV testing every 3 months until infant's age of 9 months at the Healthy Child Consultation pediatric immunization sector. It actually happened in the pediatric immunization sector when they bring their children in for routine immunization. In this context, we expect that around 3 million HIV tests per year needed only for breastfeeding women, which is a lot of HIV tests. And in order to optimize retesting for breastfeeding women and making it possible and effective, a risk screening tool to determine HIV testing eligibility was developed by the TWG. So this is an image of the risk screening tool. Really, there was a first section where we had demographic and clinical information, and then 11 questions that were deemed risk factors for HIV incident infection. The counselors at the Well Child Clinic expanded program of immunization sector were all trained to complete the tool. All women with an unknown HIV status and not on PrEP were tested as per MOH guidelines, regardless of the responses of the screening tool. And the women with an HIV positive test result were referred to care, and their exposed child referred for virologic testing and further care. The ones who were negative with risk factors were referred to PrEP services. The objective of the evaluation were broader of this presentation, highlighted in red the ones that we addressed in the presentation, which are really focused to the primary objective of determining sensitivity, specificity, positive and negative predictive value, and also secondary objectives, the associated risk factors for new HIV infection during breastfeeding in 48 selected health facilities in northern and central Mozambique. It was a retrospective analysis to assess screening tool sensitivity and specificity for detecting new HIV infection among breastfeeding women. The population were breastfeeding women with an unknown HIV status and not on PrEP. Data was collected from routine visits of breastfeeding women at the immunization clinic between August 2022 and March 2024 across selected central and northern provinces in rural, urban, and semi-rural health facilities. Data sources were paper-based screening forms, and additional data were collected from EPI registers, HI, PCR registers, and medical files at the RT clinics. Key variables were maternal age, child age, number of antenatal care visits, PrEP status, responses to the 11 questions on HIV risk, time since last HIV test result, and partner HIV status. And the tool administration was done by trained counselors, and I have to highlight that all the questions in the tool were self-reported by breastfeeding women. The sample size was 75,639 breastfeeding women with HIV negative or unknown status and not on PrEP. The observed HIV positivity rate was 0.37%. We identified 284 HIV positive cases, and the participant profile had a mean age of 24 years. 61% were adolescent girls and young women. 63% were from rural areas, 42% had already 2 or 3 children, and 56% at the last HIV test 3 or 5 months ago. So the statistical approach and the tool validation was done through variable selection of strongest predictors via L1 regularization, lasso technique. The model validation was through a tenfold cross-validation using the partial area under the curve with a cutoff of equal more than 80% sensitivity, and we used the 2-steps approach for validation. A model-based score using logistic regression probabilities for each risk factor, and simplified score to be used more at implementation level where points were assigned for each response. Sensitivity and specificity were calculated using the optimal model derived from the regularization first step and based on the partial area under the curve. So here is a summary of results. You can see that we had the 6 strongest predictors are in table 2 listed, and really the strongest predictor was the partner status, with an odds ratio that went between 1.2 and I can't read well, but I think it's 38.1. And with this 6 strongest predictor, the receiver operating characteristic curve was built. And really, the partial area under the curve was 0.587, which means that we almost missed half of the positive cases that we would have found. So to detect 1 postpartum new HIV infection among breastfeeding women, the number needed to test were 252 if we set a cutoff of 95.8 of sensitivity, and 270 if we set a cutoff of 98.9 of sensitivity. Other thing is that we had to have a trade-off between sensitivity and specificity, so if we wanted to reach a 90% sensitivity, we would lose in specificity and go down to around 30.1%. But there was something that was very interesting. That was that really the strongest predictor was the partner HIV status. So what we decided to do was to do a more nuanced 8-level classification of the partner HIV status, which was based on HIV status, ART status, and viral load status. And here we saw that actually the partial area under the curve improved to 0.606, but still required around 215 tests per case at around 90% sensitivity. The adjusted ratio went from 1.2 for this refined model to 150, which was in particular the HIV positive and on RT high viral load patients, partners. So overall, what did we learn? We learned that the tool itself did not function well, but we had a lot of opportunities for learning and improving the programs. There were some limitations to the study based on the self-reporting of many of the variables and also on implementation challenges. Immunization sector is a great integration opportunity, but it's also our own overloaded service delivery point in the health facilities. The strongest predictors of HIV risk were related to partner status, as I mentioned, And this really highlights the importance of partner testing, engagement, disclosure, joint viral load monitoring, and male engagement and family approach in PMTCT programs. And so we really learned a lot. So we did not win in the sense that we did not get the screening tool that worked, but we learned that we cannot use the screening tool in our setting, and we have to continue operationalizing routine universal HIV retesting for breastfeeding women, and this is critical, that we have to move towards more integrated service platforms. The immunization sector is an opportunity, and it can really bolster HIV prevention, screening, and linkage to care and treatment if more investments and functionality is guaranteed. And of course, that innovations such as oral and blood-based self-testing may improve early detection of new HIV infection among breastfeeding women, but also that we really need to push hard for PrEP for pregnant and breastfeeding women, because this is essential to eliminate MTCT and resource limitations as we see. Finally, thank you for this opportunity. Thank you for the women and children of Mozambique that are really so impacted, and thank you to all the colleagues who have supported this evaluation. Thanks.